Again, thank you for joining us. So I just wanted to thank everybody who's on the line, because the quote of the day is, let us take care of the children, for they have a long way to go. Let us take care of the elders, for they have come a long way. And then let us take care of those in between, for they are doing the work. And that's who I am here with, the people who are boots on the ground is the new phrase to use, doing the work for us in EMS, and that is our nurses and our EMS providers all over the state of New Mexico and the nation. So today we are going to be hearing from Verena Weissenborn, if I said that correctly.
Awesome.
And we do have some special guests, Sarah Dakin, who is an educator with us as well. If she has any comments, I'm sure she'll chime in. I'm Catherine Schaefer. I'm the program manager for the New Mexico Child Ready program. And we have with us Joan Caldwell and Laura Grijalva. And special guest is Nicole Chamney, who has been with UNM for a while. She's gone on to do many other great things, but I'm sure we'd love to hear from her if she has any comments as well. So this program overview just is a little bit about us. We are the New Mexico Child Ready program. We have a HRSA grant that is working on the regionalization of care. And for that, this piece of it, it's education. And we are trying to get some free CEs out to our EMS providers. We know that it is not easy to get from point A to point B in the state, and that we are struggling to meet the financial needs of everybody. And we want to make it as easy as possible for our EMS providers and nurses to get their CEs. So this is one free live CE as soon as we complete this evening. And we are going old school tonight. We had some technical difficulties. Joan lost her computer last week and we had to reboot. We lost connections. It was a mess. So if you will email to hsc-childready@salute.unm.edu, we will get you your nursing or EMS CE within about 7 days. Also, just to keep it real, we are taking some chat questions that you can type in to your chat section if you were joining us on the webinar. If you are joining us by phone, you can text your questions to area code 505-269-0347, and we will work through them with Verena and our guests this evening. Tonight's topic, Kids Gone Wild, Pediatrics and Emergency Medicine. We'll come back to this slideshow, but Verena, let's get you started.
All right, awesome. Hi, everybody. My name is Verena Weissenborn. Lucky for you guys, there's not going to be a test on that at the end of the presentation. I am a nurse educator for trauma and emergency at the University Hospital. The reason I'm the one to give you this presentation here today is because I'm actually a operational member with the Albuquerque Mountain Rescue here in New Mexico, in Albuquerque, obviously. I'm on the New Mexico Search and Rescue Council as a board member. Also have an international diploma in mountain medicine. And if you haven't gathered already, I love everything in and about wilderness medicine. So I'm really excited that I get to talk to you today a little bit about taking care of the little ones, or some of pediatric considerations when you have them out in the wilderness setting. Some of the things specifically we'll talk about is, what is wilderness medicine really? How about those kids in the outdoors? Very important. Pediatrics versus adult patients, loads of differences here. I've selected some common issues encountered in wilderness medicine, and very important, I think, anytime we take care of pediatric patients, it's all about illness and injury prevention, educating our families and caregivers. The first thing I want to start out with, I understand, I think pretty much everybody on the call today is somewhere from in and around New Mexico. So you probably remember this story. This is not from very long ago, just August 2015, made the national headlines on CNN. Here, French couple dies in the New Mexico desert, the son survives. So I want to talk about this real quick. As many or most of you know, White Sands National Monument really boasts a beautiful desert landscape in southern New Mexico, where temperatures in the summer frequently exceed 100 degrees Fahrenheit. We've had this family visiting from France with their 9-year-old son. They set out on a hike. Only about 1.5 miles into that hike, the mother actually fell, which in that process, she aggravated an old knee injury, which prompted her to turn around. She actually only made it about 300 feet, collapsed and died right there, overwhelmed by the heat. The father and the child were unaware of this happening, even though she was only 300 feet behind them. They continued on their hike. Meanwhile, the father became increasingly disoriented, and they only made it just about another 2,000 feet, where the father then collapsed and died, also due to apparent heat-related causes. Later on, the son was found at the side of his deceased father. He was dehydrated, but survived. So this scenario really shares many common factors with other very typical wilderness medicine related incidents. I can tell you from personal experience, I've been on somewhere around 50 missions here in New Mexico, and they all have some very, very typical, standard, common problems that I can see even in this incident again. And that's why we're going to revisit the story later on towards the end of my presentation. Ultimately, the event was entirely avoidable, and the parents' deaths entirely preventable, very sadly so. So let's talk about what is wilderness medicine. I found this quote for you here. Simon says, "Caring for injured or sick people in the middle of nowhere without the clinical resources found in a hospital setting and often under adverse environmental conditions." Really what we do out here is prevention, diagnosis, and treatment of injuries and medical conditions that may occur during activities in remote areas far away from cities, ambulances, and hospitals. Oftentimes we end up practicing medicine without medical support and with definitely the need to improvise care. But you wonder, how does this apply to me, right? So when and where does wilderness medicine really happen? Of course, if you're like me, part of a search and rescue team, it's kind of your bread and butter. Also, you might actually find during a natural disaster that strikes close to home, you'll find yourself in an environment that is very closely resembling a wilderness medicine. So here's a quote I found for you. "When Katrina hit New Orleans, an urban medical center became like the wilderness." So a lot of similarities there, actually. How about you simply enjoy spending time outdoors with your family, or maybe your friends and their families. And then lastly, you just simply happen to be in the right place at the right time. And if I think about New Mexico particularly, what kind of a rural state we are, how you can find yourself on a rural highway somewhere hours away from any kind of other living being, or definitely any kind of advanced healthcare setting, you might find yourself in a setting where you render wilderness medicine type care. So what really is the difference here? When it comes to scene safety, that is something that when you're out in the wilderness becomes a real topic. Some of the things you deal with out in the wilderness are physical dangers, whether it's rockfall, whether it's snow or ice, trees around you, fire, wildlife, weather and environment issues. Temperatures are extremely hot, extremely cold. You deal with sun, wind, lightning, high altitude, and not just yourself, but your patient for sure as well. You have other peoples around. If you're in a setting where there's climbers involved, there might be climbers above that might kick loose rocks loose. Hunters in the area, simply spectators. Other rescuers can also pose scene safety concerns. Access and extrication is a big deal because you have to first find your patient, you have to get to your patient, and then you have to figure out how to get them back out from wherever they found themselves. You end up working with minimal personnel, usually minimal supplies, rarely hardly any medications, and definitely very little equipment. You don't usually carry a defibrillator out into the field. Environmental exposure is another big deal in the wilderness setting. Because the environment has really huge potential to worsen your patient's condition and really have an effect on the medical course. If you think about it, your patient has likely been exposed to the environment much longer than yourself and has probably been compensating worse due to that condition. And then if we just think about the fact how hyperthermia contributes to the trauma triad of death, certainly a significant concern. We have to make evacuation decisions. Is this a condition that is bad enough where we actually have to evacuate somebody, or can we render a minor treatment and continue on? And then the potentially long time, the definitive care is another big issue. Even here in Albuquerque in the Sandias, I've taken care of a medical patient, and it took us somewhere around 5 hours to get him just from where we found him on the crest trail back to where we could actually put him into the back of an ambulance. Some of the special skills needed in the wilderness setting, certainly search and navigation skills. You have to find where you are, where the patient is, and how to get back out. Communication skills, travel, and that involves anything from, potentially having to climb, ice climb, and self-rescue techniques, those things. And nutritional concerns for being able to maintain yourself and or your patient in the wilderness setting for an extended period of time. Survival skills such as water finding or even just camp building, potentially technical rescue skills, patient packaging is a big deal, and then some quite specialized medical knowledge that you don't necessarily deal with in other settings quite so commonly. Aside from trauma, you deal with a lot of the environmental exposure effects such as hypo and hyperthermia. You have it listed here: burns, bites, stings, dehydration, altitude sickness, and so on and so forth. But let's go ahead and get to these kids in the outdoors. Really, if you think about it, millions of kids venture into the great outdoors every year. Family trips, school trips, camp, sporting trips. I found a report from 2014 that said that outdoor participants in the ages from 6 to 17 made 2.8 billion outings in this one year. That means an average of 88 outings per the youth participant. And if you consider what might be some of the most popular activities that kids do in that age range, bicycling came in top, followed by running, fishing, camping, so anything from car backpacking and RV camping, and then hiking. So when we talk about pediatric patients in the wilderness setting, some of the more common medical issues you may encounter here are certainly injuries, so trauma, temperature and weather related issues, hot versus cold, exposure to sun, wind, precipitation. We deal with stings and bites, and then altitude, certainly in our part of the country as well. One thing that's been drilled into all of our heads all along, right? Children are not small adults, and there's really a lot to say about that, because what we're looking at here is huge differences in terms of anatomy, physiology, and development that will particularly influence how children are affected by some of the wilderness type illnesses, or injury and illness sustained in the wilderness setting. So some of the important categories to look at: airway and breathing here, head, neck, spine, thorax, abdomen, extremities, body surface, skin, and then their developmental stages as well. Starting out here with airway and breathing, we've all heard that infants are obligate nose breathers until about 4 to 6 months of age, and that's really significant because how often, how potential could they have, any kind of nasal secretions. Even a small amount of secretions can cause significant airway obstruction in these little guys. Thinking about the larger tongue here as well, particularly if you have a pediatric patient that you place in the supine position, that larger tongue tends to obstruct the airway. Smaller airways, again, even a small amount of secretions can markedly increase airway resistance and result in partial, if not complete, airway obstruction. The faster respiratory rate that we see in kids is significant for the wilderness setting because, first of all, it contributes to greater insensible fluid loss. Also, if they're exposed to any kind of toxic gases, such as if they're around a fire or so, they actually suffer from increased uptake of those toxic gases. Children have a, relatively speaking, high metabolic rate and oxygen consumption, which really puts them at high risk of hypoxia occurring more rapidly, and hypoglycemia, of course, occurring more rapidly as well. Lastly, then, here the diaphragm is essentially that major muscle for breathing in kids. So any conditions impeding diaphragmatic expansion can then contribute to respiratory distress. So things like gastric distension, for example. Next here on the head, neck, and spine, head injury is the leading cause for trauma, morbidity, and mortality in kiddos. So the large head here, just merely putting a small child into the supine position can cause that flexion of the airway that then causes obstruction unless we have padding under the shoulders. And we're really looking at until age 8 here about. The cranium is more pliable, especially in the younger kiddos, so they're more prone to skull fractures. And then on top of that, let's add some lax ligaments and that incomplete fusion of the vertebrae, also again until about age 8, so they're predisposed to head and neck trauma, and then this condition that we know as SCWORA, so it's the spinal cord injury without radiographic abnormalities. So certainly in the field we wouldn't know that that's the problem, but if there's any kind of neuro symptoms, neurodeficits, or tenderness, of course we would have to immobilize the little ones. Speaking about the thorax, here we're dealing with the fact that children are more susceptible to blunt chest and abdominal injuries simply because of their height, the flexibility of their ribs, and then on top of that, the rib orientation. The bones are more compliant, which means we actually see less fractures of the ribs and sternum, but they're at greater risk for injury of the organs beneath. That rib orientation, as you can probably make out quite nicely with those radiographic images, is more horizontal in the child as opposed to more vertical orientation in the adult. So what we have is, number one, the chest diameter is essentially maximally expanded at baseline already and can't be increased with distress. But then what that also means is that the abdominal organs are less protected because of that rib orientation. Which leads us to the next problem, or the next area here, the abdomen. So especially the little kids, right? Nice protuberant abdomen, weaker abdominal muscles. So again, what you have is less protection of those underlying solid and hollow organs. Relatively speaking, the intra-abdominal organs are larger, which essentially has them more exposed and at greater risk for injury. Then the sigmoid and the ascending colon is not fully attached, which places the child at higher risk for injury with deceleration mechanism of injury. A few words about the extremities, body surface, and skin here. That larger body surface to mass ratio puts the children at greater risk for exposure to environmental factors such as cold, heat, solar radiation, all the while also being at risk for greater insensible fluid losses, which places the children at greater risk for dehydration than adults. Children have less mature thermoregulatory mechanisms, which again makes them more susceptible to heat illness and hypothermia. They have thinner skin, which means they actually sustain more significant burn injuries from exposure to less heat. And let's talk about these, the musculoskeletal system. What we have here is compliant bones with a strong periosteum. So injuries to the open growth plates are common. We see things like buckle fractures, green stick fractures. So essentially, assume that there's a fracture if you palpate tenderness over the joint and go ahead and splint and immobilize. And then how about this hemodynamic stability, right? So there's a number of different resources that I've found out there. Some say about 20 to 25% of blood loss until children show hemodynamic instability. One reference I found actually says up to 40%. What happens, right? Children cannot increase their stroke volume significantly. So instead we have an increase in heart rate and vasoconstriction along with that. Hypertension, a very late sign in children. What we want to do is pay close attention for signs of shock, such as tachycardia, pallor, mental status changes, delayed cap refill, of course, and decreased urine output. In terms of development, think about small kids, how they explore the environment with hands and mouth. It can definitely cause some problems in the wilderness setting, what kind of places those hands might be stuck into, what kind of things go into the mouth. They are easily distracted and impulsive. I think the image of the little boy chasing the ball into the street is kind of the classic thing we think about with being distracted, impulsive, and not even realizing what all is happening around. Little concept of cause and effect. They have difficulty localizing sounds. When it comes to the visual field, think about where the eye level is of the child and what children, what they actually see. And they actually, especially younger kids, tend to focus on a single object that is somewhere at their own height. And then, of course, young children do not always realize the consequences of their actions. Some more general pediatric care considerations. Everything in peds essentially is weight-based, right? So medications and fluids calculated on the child's weight in kilograms. And where that is actually something that becomes important is not just in terms of medications we administer, but think about wilderness setting. So envenomation with a snake bite. Essentially, the child is at higher risk, not just because they're at higher risk of sticking their hands into places where they shouldn't be going, but actually the dosage that they get is going to be larger relative to their size as compared to an adult. So per kilogram weight, they actually have an increased dose of venom in snake bites. When we have to deal with fluid resuscitation measures, of course, if we have such things as IV or IO tools accessible, we want to quickly go to the IO if unable to get an IV. Remember, of course, 20 cc's per kg fluid bolus as needed ×2, and then we want to consider about going towards blood, 10 cc's per kg, and always with kids, we need to consider their need for maintenance fluids. Pain management is important. We can't manage pain appropriately unless we assess it appropriately, so we want to use appropriate pain scales. And we always want to remember that there can be long-term consequences from inadequate pain control. Family-centered care is important. We want to make sure that our family gets to be with the child as much as possible. We want to involve parents, caregivers with the care and treatment as soon as possible. And then when it comes to a few things I think to remember, is really important to think about skin assessment, which yields much more information than a blood pressure in a child. Kids stay stable longer, but they decompensate very, very quickly. They have significantly higher metabolic needs in comparison to adults, kind of like twice the metabolic rate than adults. So we want to consider glucose assessment and treatment early, simply because of those increased metabolic needs and their inability to store to go along with that. Trauma in the wilderness setting, many of you obviously are familiar with pre-hospital trauma life support, ATLS or TNCC, and we have our ABCDE. In the wilderness setting, the March mnemonic is much more applicable. Similar categories here, we have the massive hemorrhage management, airway with C-spine stabilization, respiration, circulation. That age is different. So this age is really important because, as I mentioned earlier, hyperthermia and hypothermia has to be considered because that environment has such a great potential to worsen the patient's condition and really negatively impact the medical course of the patient. Always think about how the patient has probably been exposed much longer to this environment and has been compensating worse. When it comes to the evacuation plan, that has to be considered very early also. We want to consider stay and play, load and go. Really key here is that simply transporting the patient ourselves, if you are with a rescue team, you're already looking at potentially several hours. Think about if you have a critical patient. So even here in Albuquerque, in the Sandias, if we have to get the National Guard Black Hawk up on top of the mountain, it takes an hour and a half from activation. So you really want to start this process early. And speaking about hiking, the next slide you'll see in just a moment, I have some common hiking distances to guide how far can a kid actually hike, but we'll get to that in a minute. Another acronym that we use, RICEs, everybody knows RICE, rest, ice, compression, elevation. Stabilization is really important in the pre-hospital environment because we want to prepare the patient for transport. So that could include anything like taping or splinting that affected extremity. All right, I promised a little guide here on hiking distance for children. So quite interesting. Well, of course, the 0 to 2-year-old, the travel distance is going to be dependent on the adult. They'll be in some form of child carrier. And those of you who haven't carried a kid on the back, it's definitely something to consider. That weight, even a 1-year-old already is going to be heavy. 2 to 4-year-olds, they can actually hike 1 to 2 miles on their own, but boy, is that a difficult age, right? So they have to stop essentially every 15 minutes. A little bit older, 5 to 7-year-olds, they can hike 1 to 3 hours a day. It's really quite impressive, I think. So kind of on easy terrain, of course, and they do need rest every 30 to 45 minutes. Once you have the 8 to 9-year-old age group here, they can hike essentially a full day. If it's an easy pace, they can cover about 6 to 7 miles over variable terrain. Really good to know is once they're over 4 foot tall, they can actually carry a framed backpack. But you want to make sure what they carry shouldn't exceed 20% of their body weight. 10 to 12-year-old, they can hike that full day at a moderate pace. They can actually cover 8 to 10 miles over variable terrain. And the teens, not much longer. You're looking at about 8 to 12 miles at that adult pace. Interesting to remember is that teens go through growth spurts and they can actually impact the pace and distance of the child. So it might, at the time of growth spurt, their pace or distance might actually be lesser. Yes, ma'am.
Well, just while you're on here, I just want to make sure that everybody can reference where she's getting this information from. I thought this was really interesting information and very helpful. So it's the Field Guide to Wilderness Medicine down at the bottom.
Oh, thanks for pointing that out. Yes, that's Auerbach. He's a quite renowned author in the area of wilderness medicine. He's had a lot of a lot of publications. Definitely some good material there that he's brought out. Thanks for pointing that out. All right, let's talk about illness related to exposure and environment. Some of the topics I picked are dehydration, hypothermia, hyperthermia, altitude, and then stings and bites. We'll start talking here about dehydration. Bottom line is children are at greater risk for developing dehydration than adults. When it comes to signs and symptoms, we have those categories of mild to moderate dehydration. I think that's already pretty significant. The source I found I listed a 5 to 10% weight loss in this category. The child may be irritable, have sunken eyes, dry mucous membranes, be thirsty, have dark urine, and be tachycardic. And then severe dehydration, according to the source, was classified as greater than 10% of weight loss. So now we're looking at lethargy, extremely sunken eyes, extremely dry mucous membranes, cool, mottled extremities, rapid thready pulse, tachypnea, absent tears, and at this point, no urine output. So treating dehydration in the wilderness setting, what you're aiming for is to replace both fluids and electrolytes. Simply drinking plain water is likely inadequate for dehydration in the backcountry. Here, Auerbach, that source that I used for this particular information, says that you can use Gatorade, but he actually recommends diluting it to have strength. There are commercial oral rehydration solutions out there, referred to as ORSs. They contain an admixture of sodium chloride, potassium chloride, glucose, and bicarb, and that then needs to be added to disinfected drinking water. So this is already kind of, as you hear some of these things I'm saying, you know, some of the things you might want to think about is, what do I need to pack when I go out into the wilderness? So having some way of creating clean drinking water is definitely a good consideration, which also, by the way, in the wilderness setting, we say, if the water is clean enough to drink, it is clean enough to irrigate wounds. So something to remember is definitely having maybe some iodine tabs or such in the pack is not a bad idea. Going back to these oral rehydration solutions, there are various recipes out there for making your own. And there's, you can basically, there's a recipe of how to mix table salt and sugar with disinfected water. And there's even a rice cereal and table salt with water mixture out there. So various recipes that, that could help with treating dehydration. If the patient is severely dehydrated, that requires obviously prompt medical attention, would require IV fluids for rehydration, this is somebody who must be evacuated. Talking about thermoregulation, next here, just a quick reminder of the 4 mechanisms at work for how we thermoregulate in general. So evaporation is actually the most efficient way for thermoregulation. So at an average temperature, you're looking at about 30% of body cooling via this mechanism. So this is when we sweat, right? Radiation involves the transfer of heat from our body via electromagnetic waves. And you can actually have over 50% of cooling, but for that purpose, the ambient temperature actually has to be cooler, obviously, than the body temperature. Conduction, that is where you have the transfer of heat between 2 objects that are in direct contact. So that's not very effective unless it is really significant, like lying on cool ground, picture lying in snow, immersed in water, those type of things, which is why actually when it comes to treatment of things like heat stroke, you're actually talking about immersing people in ice water. Convection, that is then the transfer of heat between the body and moving gas or liquids or air or water. And to consider is here that the rate of the heat transfer then is affected by the speed of the movement and the temperature of each of the substances involved. So one way, for example, that this plays out is if we have spray water on ourselves and then start fanning that, we're actually creating that mechanism of convection for cooling. Leading from the general concepts of thermoregulation to the more specific instances here. Hypothermia, let's talk about this first. Again, children are at greater risk for developing hypothermia than adults. Why is that so? Again, remember what we talked about earlier. They have this proportionally large body surface area to their mass. So definitely more at risk for cooling more significantly, more rapidly. And then also thinking about the development of kids where simply they lack the knowledge and judgment to initiate those responses that would maintain their warmth in a cold environment. Some of the signs and symptoms you might see are ataxia, an altered mental status, inappropriate remarks perhaps, and please, when it comes to kids particularly, don't rely on the presence of shivering. How do we treat it? Very important. One thing, if you think about those mechanisms, we just talked about thermoregulation. So one thing that really contributes to people, particularly out in the wild, getting really cold is because they're wet. So we want to get anything wet off of them, replace that with dry insulating clothing. We want to make sure the child's head and neck are covered. Place the child in a sleeping bag if you can with a normothermic person together to hold them warm. If the child is alert, you can consider using oral hydration with warm liquids containing glucose. Very important, if the child is severely hypothermic or is not improving with the measures you're doing, definitely evacuate. And then also important, of course, when it comes to hypothermia, we want to think about how can we prevent this from happening, right? So one thing that we always say is cotton kills. So cotton, because it gets wet and then it stays wet and it cools you down. So wool or synthetic fabrics are probably going to be much better. Dressing in layers is important. For kids particularly, hats, mittens, appropriate footwear. And then we want to make sure that they stay well hydrated and they have high energy food intake. We need that to be able to stay warm. Leading to the next topic of hyperthermia. Again, you've probably already about tired of me saying it, but even with the hyperthermia, again, children are at greater risk. Anybody still interested in taking kids into the wilderness? Children are at greater risk for developing hyperthermia than adults. So what is hyperthermia? So we're not talking about a fever here, right? So in this particular case, the hyperthermia develops when the heat stress is greater than the heat dissipating capability. Why are kids at greater risk? So they generate more heat per kilogram. Again, they have this greater body surface area to mass ratio, which means they have increased exposure and an increased risk for dehydration, as we mentioned earlier already. On top of that, they're less able to dissipate heat from the core to the periphery. They have fewer sweat glands, and they have less sweat production per gland. So they get not even just a double whammy, they're certainly at a disadvantage. Some concepts to think about when it comes to hyperthermia, heat cramps. Those are muscle spasms that individuals typically experience in their legs and abdomen. We consider those early warning signs for heat stress. Heat syncope, what happens there is somebody faints immediately after strenuous work in a hot environment, for example, because the blood vessels dilate in the body's attempt to cool themselves off, right? And so they pass out and they come back quite quickly, typically. We have heat rash. You can see that in kiddos. Prickly heat is what that is referred to commonly also. Essentially, you have blocked sweat gland ducts that lead to inflammation and then the development of these erythematous pruritic papules. Heat exhaustion, here we have heavy sweating, weakness, nausea, vomiting, some mild confusion, and then the heat stroke, that is a true emergency. We're talking about high body temps. There's various references. The majority of references I have read refer to a temp that's greater than 105, so greater than 40.6. I think the lowest temp I saw was on the CDC website at 103, but like I said, the majority of resources I've seen rely on that 105, so that's a 40.6 Celsius temperature. We have hot red skin that can be dry or moist. Don't rely on that not sweating part to see heat stroke. We have a rapid strong pulse, altered mental status that can be ataxia, can be confusion, can be possible unconsciousness. General treatment for hypothermia in the wilderness setting, of course, remove the child from sources of heat, remove the clothing, right? Spray them with warm water and fan it vigorously. Place ice packs or cold compresses at the neck, the axillae, the scalp, the groin. If they're alert and not vomiting, administer oral fluids. Very important though, if you have any inkling that this could be heat stroke, don't even go academic on this. If it looks anything like it, just treat it as such. Heat stroke requires rapid cooling and rapid evacuation. Heat stroke can be deadly, right? So this is an absolute emergency, and the mortality in this case relates to the degree of the temperature elevation, the time to the initiation of cooling measures, and the number of organ systems affected. So that's a pretty big deal. How do we prevent hypothermia? Really quite simple, right? We all know this, wearing loose layers, wearing a sun hat, encouraging hydration, avoiding outdoor activities or exertion in the middle of the day, and taking frequent rest breaks. So nothing, no rocket science here. The next topic I want to talk to you about is altitude and acute mountain sickness. Acute mountain sickness is a continuum of illness that occurs hours to days after somebody has ascended to an altitude that's above 2,000 meters. Since it is a continuum, it can range in severity from mild, self-limited to potentially fatal. When it comes to signs and symptoms of altitude or acute mountain sickness, the Lake Louise consensus criteria are used generally. Essentially, acute mountain sickness based on those criteria is present when somebody is at altitude, has a headache, and has at least one of the following symptoms. That would be dizziness or lightheadedness, fatigue or weakness, nausea, vomiting, or anorexia, or insomnia. Now in infants, I don't know that we can go with the Lake Louise consensus criteria, but some of the symptoms we might see here are irritability, poor feeding, and sleep disturbance. I've listed on my slide here HAPE and HACE. Those are both genuine medical emergencies. Delay in treatment can be fatal. In both cases, the key treatment is you must descend immediately. If at all possible, you must descend. So what is HAPE? That is high altitude pulmonary edema. Those individuals have dyspnea at rest, cough, exercise intolerance. Occasionally you might see pink frothy sputum. They may have neurologic signs as well. So on assessment, you would find tachycardia, tachypnea, rales, crackles, central cyanosis. Mild cases may resolve within hours after descending. Severe cases may progress to death within 24 hours, especially if the descent is delayed. So this is pretty serious. HACE is high altitude cerebral edema. Is essentially, if you think about the signs or symptoms we talked about for acute mountain sickness, it's just super severe with additional neurologic dysfunctions such as ataxia, altered level of consciousness, and in this case, progression of acute mountain sickness then to coma can occur over 1 to 3 days. So generally speaking, treatment for altitude sickness is discontinue the ascent and rest. Descent is the definitive treatment. Oftentimes, it's only about 500 to 1,000 meters, may already be enough. Supplemental oxygen can improve symptoms rapidly. And then in terms of medications, acetazolamide is used to facilitate acclimatization, sometimes used in severe AMS with Decadron as well. How do we prevent it? Facilitate acclimatization via graded ascent. You want to avoid an abrupt ascent to greater than 3,000 meters. You want to avoid abrupt increases in sleeping altitude of more than 500 meters per night. A few other things I want to talk about, some stings and bites here. Children are once again at greater risk for being bitten or stung and more susceptible to the toxic effects than adults, as we talked about earlier. Kids under attack. What do we have out there? Snakes, ants, bees, wasps. They're also referred to as Hymenoptera. Mosquitoes, spiders, ticks, scorpions, all the kind of good stuff. And I stuck to the little animals. So speaking of snakes, in North America, we deal with 2 types of poisonous snakes, the the pit vipers. In that family, we have the rattlesnake, the copperhead, and the water moccasin. And then not so common, the coral snakes. The majority of bites in North America are from the pit vipers. Interesting to know that actually 25% of the bites are dry, but that's not ours to decide in the field. The US pit viper venom is hemotoxic, with the only exception of the Mojave rattler, which is actually neurotoxic. 20% of deaths related to snake bites are in children under the age of 5. That's all. So, I mean, that's significant. On the other hand, I found a resource today that was talking about somewhere around, I think it's 7,000 to 8,000 snake bites, reported snake bites in the United States per year, 5 deaths associated with that per year. So the overall numbers are fairly low. This reference here I found had 57 deaths in that time span from 1991 to 2001. So what do we do for a snake bite? They have to be emergently evacuated. Key, of course, we want to support the ABCs. Just like with much else that we do. We want to minimize physical activity. They're not supposed to be exerting themselves anymore. They have to be calm, kept calm, especially in the kids, right? We want to splint the extremity. So essentially kind of splinting is similar to the way you would do it with a fractured extremity. You want to remove anything that could create a tourniquet effect as the swelling kind of comes into play. So clothing, jewelry has to be taken off. And you want to kind of keep an eye on that swelling and mark that forward edge of the envenomation site every 15 minutes, because that can then help track how bad it was, how bad the child is affected. Some of the old myths out there, please don't fall for those. They either don't work or they might actually be harmful. So there's some commercially available extractors. Don't bother. Don't cut and suck on that wound. Don't apply a tourniquet. Don't use alcohol, neither for cleansing of the wound nor for pain control. No aspirin. We just said that the venom is hemotoxic, of course. No packing of the limb on ice. There are some studies out there related to cooling, but the jury's not out yet, so don't pack it on ice. No electric shock I came across. I don't even know people considered doing something like that. Very interesting. And here last one. So don't attempt to catch or kill that snake. Actually, the article I read today was in the Emergency Nurses Journal that was actually just came out, I think, last week or whatever, and it was an article on dealing with snakes in the hospital. Nobody wants that snake there, not dead nor not alive. Really important to remember, and you'll find actually there's different resources, references out there. Some people will say you should maybe try to get at least some kind of description of the snake, maybe take a photo. If it's safe to do so, do it, but otherwise you have to be really careful. Even a dead snake can still lead to envenomation. So you don't want to be in contact with that. Like I said, nobody wants that in the hospital either. When it comes to prevention, teach kids not to reach into crevices. Basically, don't put your hands or feet where the eyes can't see, right? Don't overturn rocks or logs. If you choose a campsite, if you're traveling with a child, don't choose it next to wood or rock piles. Then we have our class or group of Hymenoptera, that's ants, bees, and wasps in that category. And if you were cringing about snakes, listen to this. More people die in the United States from bee, hornet, and wasp stings than any other animal bite or sting. That's pretty serious right there. In an allergic person, we all know one sting can be fatal in minutes to hours, right? So how about this? In the non-allergic person, you can actually get fatal toxicity levels from multiple simultaneous stings. The resource I found actually talks about 500 to 1,400 simultaneous stings. I'm just going to leave that up to you guys what you think about this. So that's pretty serious. In terms of symptoms, of course, we've all had some kind of sting or bite before. You most commonly get that local reaction, a kind of small red patch that burns or itches. You could have symptoms, of course, of a general reaction with symptoms of anaphylaxis, and then stings to the mouth and throat, particularly concerning because of the risk for airway swelling. In terms of treatment, you want to remove the stinger if it's there. Ideally, scrape it away in a horizontal fashion, they say. The bottom line is it has to come out some kind of way. So if you can't get it out in a horizontal fashion, just get it out. You want to clean that site with soap and water. Place cold compress or ice to that site. Consider oral analgesics or antihistamine. Very important though, if there is an anaphylactic reaction, we want to administer epinephrine. Again, think about, as you're hearing this, what kind of things do I might have to consider putting in my pack or whatever I carry along on my trip. 0.01 milligram per kilogram of the 1 to 1,000 epi is the dose, Sapura IM. You have the Commercial products, of course, the EpiPen Junior and the EpiPen 0.3. So EpiPen Junior is 0.15 milligrams. You give that to kids less than 15 kilograms. The 0.3 milligram is for kids greater than 15 kilograms and adults. We also have mosquitoes and ticks out there, of course. Mosquitoes, we know, transmit diseases. Research has shown, I don't know that I would want to be a research participant for this one, but they found the best protection against mosquitoes is actually permethrin-treated clothing. So permethrin is not a product you can put on skin. You can put it on clothing. You can put it on mosquito netting, and then combine it with actually spraying DEET on yourself, max strength 35%, or picaridin-based repellents. That's considered the best protection against mosquitoes. When it comes to ticks, those guys found in areas replete with woods, shrubs, and trails, often found at forest boundaries where deer and other mammals reside. They actually sit on low-hanging shrubs, kind of legs spread out, until the animal passes, and then they jump. Once they make contact with the host, and this is important to remember, it can take up to several hours until they find a suitable spot where they bite. So, of course, ticks, we know, transmit diseases. So, but think about what I just said about how it can take several hours until the tick actually latches on. Checking clothing and exposed skin for ticks at least twice daily is a recommendation. Also for protection against these guys, the permethrin-treated clothing plus DEET is recommended. If a tick actually has implanted itself, has bitten into the skin, we want to remove that by grasping with trees. There's a whole list of things, of the do nots, right? We've all heard the various stories. Here's the recommendation. Use tweezers or forceps as close to the skin surface as possible, and then gently pull straight up. Okay, forget about the tips and tricks that you've learned from grandma. Clean that bite with soap and water, monitor for infection, of course. Here's something really interesting. Removing the tick in a timely manner, again, this is why it's so important to check at least twice daily, can actually prevent disease transmission. So Lyme disease, if the tick is removed within no more than 48 hours, there's actually only rare contraction of Lyme disease. So I think that's really something interesting to know. We have spiders and scorpions out there too. Anybody cringing yet? Spiders? Actually, most of them simply do not have enough venom to affect a human, nor are their fangs large enough to penetrate human skin. Really, in North America, we're only dealing, lucky us, with 3 significant types of spiders: the black widow, the brown recluse, and the hobo. In this case, actually, with spiders, the recommendation is try to catch it if you can. So even if it's smashed, they can still be identified under the microscope, right? Yeah. You want to clean the bite with soap and water. Really, you should get medical evaluation. The black widow bite particularly really needs to be evacuated right away. There's big issues with pain control that come from those bites. In general, long-term outcomes are good. The brown recluse spiders, we know that they can create some yucky wound sites, but actually the majority of their bites remain localized, and they heal within 3 weeks without serious complications or medical intervention. The hobo and the funnel web spiders, they mostly require supportive treatment and pain relief, or medications. Scorpions, they do live in North America. I'm sure, as we have a lot of folks from New Mexico on this call, you are well aware of this. They live in semi-arid to arid environments, kind of in that 50-degree latitude north and south of the equator. Really, for the most part, their bites result in, or stings really result only in local pain and inflammation. It's very similar to the Hymenoptera stings, so like if you get a bee sting or something like that. But we have this wonderful scorpion around here, the bark scorpion, and it can be much more significant. In general, recommendation is make sure you check your clothing for scorpions, shake out your shoes, and if you are in areas that are common to scorpions, yikes. Let's talk about this bark scorpion real quick. Somebody stung by a bark scorpion needs to be evacuated ASAP. This can be lethal to infants and elders. Where do these bark scorpions live? Well, guess what? In New Mexico and Arizona. So what you get here is local pain followed by numbness and tingling. There is unfortunately a neurotoxin involved that can cause paralysis, muscle spasms, breathing problems, vision problems, swallowing difficulty, slurred speech. Ultimately, death is related to loss of airway control, loss of respiratory muscle control, metabolic acidosis, and a bunch more conditions that all come in that follow that neurotoxin that is released there. So very important as you're doing your evacuation and get them to emergent medical care, you have to keep a close eye on our March primary survey steps. Yes, ma'am.
So for that particular scorpion, since I'm not familiar with it, you might want to Google that if they wanted to get a picture of it. Because I know we have scorpions all around Albuquerque.
I see somebody here at the table has already Googled
Yeah.
this box scorpion.
I want to make sure I know exactly what that one is.
Yeah,
like
yeah,
the
yeah.
next time we go on camera.
Very good, very good. So a quick word here about illness and injury prevention. We're gonna go back to this story that I talked to you about at the very beginning of my presentation, the French couple that died in our White Sands Monument Desert. So let's think about how this tragic event really could have been avoided. I mean, of course, we could just stay out of the wilderness altogether, but what fun would that be, right? We love going outdoors and doing fun things. So really, there's a number of preparations and precautions we can all take to prevent bad outcomes. And doing so can not only keep ourselves safe, but it can also kind of guide how we educate others as they prepare for outings. So in this particular case, really, as I reflected on it, the contributing factors, in my opinion, are really quite typical and very similar to many search and rescue missions that I've been a part of. And really they include, or really more so the lack thereof, overall trip planning, environment and exposure, navigation and familiarity with the terrain and hazards, and communication. So overall,
I totally did it back.
got a little bit too far
I
here.
was trying
There we
to get them. I thought there was something else that came
go.
up
No,
on the slide.
so overall trip planning includes things like, what's the physical fitness and condition of my participants? How long is this trip going to be? What time of day do we start this trip? I would like to ask this question many times when people go on the La Luz at 3 o'clock in the afternoon, right? What type of packs do I carry? What kind of footwear do I need? How about some things like, do I need lighting? Flashlights, headlamps? How about any kind of specialized gear? Do I go into terrain that will require ropes, technical equipment? Do I need a helmet? In winter environment where I might be better off with an avalanche beacon, winter travel equipment. So there's a whole lot of things, of course, to consider in that realm. Basic things, food, water, first aid supplies, medications that if you have a chronic illness, make sure you have stuff with you that you need, right? If you are a diabetic, do you have what you need to take care of yourself? You're an asthmatic, do you have your inhaler, your rescue inhaler with you? You have anaphylactic reactions against these things. Do you have your EpiPen with you, right? Basic things, technically speaking. So let's look back at this particular incident with this poor family from France. In this particular case, when it comes to trip planning, the trail is only 4.6 miles long, but according to their website, it actually can take a half a day to complete. Frequent rests are recommended, and the general water recommendation is a gallon of water per day per person. For this particular hike, they said to bring at least 2 quarts of water per person on this hike. The family of 3 brought 2 20-ounce water bottles. So definitely some issues related to trip planning. Environment and exposure considerations, right? What kind of clothing do I need? Is it going to be sunny, raining, snowing, wind, hot, cold, wet? Do I need sunglasses, a hat, sunscreen, bug spray? If I travel to certain regions, of course, maybe how about my vaccinations? So in terms of environment exposure in this particular case here, it was important to note that the trail offers absolutely no shade. There's temperatures regularly above 100 degrees Fahrenheit during that particular time of year. Navigation and familiarity with the terrain and hazards. Always important to know what are the specifics about the trail and the terrain I'm going into. How long is it? How difficult is it? What kind of wildlife lives there? Bears, snakes, right? We talked about a few other animals. How about carrying a map? Navigation tools, compass, GPS. So when it comes to being familiar with the terrain and hazards, in this particular case here in White Sands, this trail is actually not visible on the ground. There's not an actual trail that you follow. You have these signpost markers, and they can get blown over with the wind. We know how the wind can blow here in New Mexico. So the recommendation is actually, in terms of know your hazards, right? If you add one marker, and you can't see the next marker from there, you're supposed to turn around. So per the surviving child, the father actually was disoriented and kept telling the child, the vehicle is over here, the vehicle is over here. Lastly, then, communication is a big thing that I see time and again, again, the lack thereof. You want to make sure you communicate your travel plans to family and friends. Somebody needs to know where you are and how long you're supposed to be out there. Assure that you have some form of communication capability, a phone with a charged battery, maybe a radio, maybe even just a signal mirror so you can signal that you're in distress. So this is something really heartbreaking about this story also. So in this case, actually, the deceased mother, we talked about how she turned around and then really fell, you know, after collapsed after about 300 feet. She was actually found completely incidentally by 2 park rangers. And it was somebody then in that group that ended up, I think it was actually a law enforcement official that ended up reviewing the victim's camera because they were wondering why is she out here by herself. On her camera, they found pictures of a male and a child at the entrance of the park. So that's the only way they knew there's 2 more people out here. And they initiated a search and rescue mission that then located the deceased father and the child. So in all, it's a really tragic story and certainly a lot of lessons to be learned from that. Some simple safety considerations when it comes to wilderness travel with kids. For a 0 to 2-year-old, provide a safe play area, right? That could be bringing in, putting it on the 10th floor, maybe an extra tarp that's laid out, adding some bells to their shoes. The 2 to 4-year-old, dress them in bright colors, teach them how to use a whistle, you know? The 5 to 7-year-old, they should carry their whistle, they should carry their own pack, have them carry a mini first aid kit, their own water, those things. The 8 to 9-year-old, you can teach them how to use a map, you can teach them how to do route finding. The 10 to 12-year-old should be able to use a compass, you can teach them. And then certainly for teenagers, you can expand on their knowledge of survival skills and wilderness first aid. There's a really cool program out there called Hug a Tree and Survive. It was created by Ab Taylor. There's a long story behind it. I won't go into that right now, but look it up. I put the website here. It's www.nasar.org/hug_a_tree_program. So it is now administered by NASA, which is the National Association for Search and Rescue. Has been translated into Swedish. There's a big program in Canada based on this as well. It's a 45-minute course that teaches kids how to survive in the woods if they become lost, some basic principles for staying safe in wilderness. Most appropriate ages, 5 to 12. It's a little bit more narrow, 7 to 11, but you can expand it, 5 to 12 years old. Some of the things kids learn in this program is how to carry whistles and when and how to use them, how to make a shelter from a trash bag, how to use an emergency reflector, what type of clothing to wear, how to stay safe when alone in the wilderness, and even how to respond to searchers and how to signal a helicopter when the helicopter comes to look for them. And there's been children saved that reported back that this was the program that taught them how to do that. So it's pretty cool. When you go on that website, you can find instructors that are certified in teaching this.
I need that for adults.
Oh yeah, okay. I think there might be an adult version out there somewhere. Otherwise, for U.S. medical providers, there's a variety of training out there for wilderness medicine. The WFAS, or Wilderness First Aid course, is a 16-hour course with the most basic knowledge. You do not have to be a healthcare provider to do this. Same with the Wilderness First Responder. That's a 40-hour course, a little bit more comprehensive into the wilderness emergency medicine. EMTs can do their EMT wilderness upgrade, so it expands on that initial EMT training to prepare rescuers for emergency on the mountains. We have the Advanced Wilderness Life Support. It's a 3-day course developed at the University of Utah School of Medicine. You have to be a medical professional. I think it's medic and up to be able to take that. Same with the Wilderness Medical Associates International course called Wilderness Advanced Life Support. That's a 4 to 5-day course. And then the program that I did here at the University of New Mexico EMS Academy is the International Diploma in Mountain Medicine. It's actually a 1-year-long course. It's the gold standard for mountain medicine, again, for medical professionals. Other resources you can find are with the Wilderness Medical Society, the WMS, that provides advice and guidance to medical personnel. They have the Wilderness Environmental Medicine Journal, the Wilderness Medicine Magazine, and they release practice guidelines for wilderness emergency care. The Mountain Rescue Association, MRA, is the oldest SAR organization in the US. They aim to improve quality, availability, and safety in mountain search and rescue. You have the ISMM that really focuses on research to improve mountain medicine worldwide. That's the International Society for Mountain Medicine. You have the National Outdoor Leadership School that teaches courses in environmental ethics, technical outdoor skills, leadership on extended wilderness expeditions, and so on and so forth. And even our own University of New Mexico EMS Academy is a great resource. They teach the DIMM, they teach the WOFA, the Wilderness EMT upgrade, and they have a wilderness medicine fellowship for emergency residents as well. So super cool resources out there. And I think we've actually reached exactly 8 o'clock here. I don't know that I left any room for questions.
I'm going to leave it open for just a few minutes. I don't have anything that came through with my texting messages. I'm looking to see if there's any up here. Oops, let's see if I can get that back up. No chat questions here. But I want to just invite everybody to send in your questions, or I can try and unmute you if you had questions you wanted to ask.
Or feel free to email questions also. I'll be more than happy to answer questions at a later time as well.
And you had a lot of information in your slides, and I want to know if the viewers asked, could we get them a copy of your presentation?
I'll have to see about the actual notes, because the slides themselves don't have all the information, so we can see if we can put something together for that purpose.
Okay, that's perfect.